Well, today we shall discuss about different types of mastoid surgeries. How to define mastectomy? It is defined as surgery performed on the mastoid to remove disease from the mastoid bone. It can be classified in different ways, but the common ways of classification are: first is according to status of bony canal wall. It can be divided as canal wall up or canal wall down according to bony canal wall status. If the bony canal wall is kept intact, it is called as the canal wall up technique. The examples are cortical mastoid surgery and combined approach tympanoplasty. So if the canal wall is taken down, it is broken down, then there are two surgeries, that episiotomy and modified radical or radical mastoid surgery fall under this group. According to extent of soft tissue or bone removal, it can be classified as cortical mastoid surgery. Only mastoid cortical bone along with the disease mastoidations are removed, and modified radical or bone-disease mastoidectomy or radical mastoid surgery, which we will be describing subsequently. What are the aims of performing mastoid surgery? The basic aims are to make the ear safe by eliminating cholesteatoma, granulations, and chronic infection. As you know, CSOM AA disease is a chronic ongoing infection. Second is to make the ear problem free for all usual activities of daily living, like swimming also, because patient can do water activities when the patient undergoes mastoid surgery and canal wall reconstruction. So to restore or improve hearing whenever possible. So sometimes if it is possible, we will improve the hearing. Otherwise, if not, then we can restore the amount that was present before surgery. To provide an acceptable cosmetic appearance. There are different approaches for mastoid surgeries. The commonly performed approaches are endural approach. This is Lempert's endural approach. So this is the endural through the interior part of the pinna. This is the endural through preauricular part. This, whilst post-auricular incision is made around 5 mm posterior to the post-auricular sulcus or retroauricular groove. Then extended endural incision and circumferential incision are also commonly used. Coming to different canal wall up procedures, advantages of canal wall up procedures are: the externality canal retains its normal appearance. Hearing aids can be easily fitted in the canal, suppose when the patient is having some form of hearing dysfunction. No routine cleaning of ear is required. Suppose if you do canal wall down technique, then patient has to come for ear cleaning routinely. There will be high tolerance for water exposure. Patient can do their daily water activities like swimming, diving, each when they undergo canal wall up procedures. Suppose when the patient undergoes canal wall down procedure, patient cannot tolerate the water exposure. The disadvantages of canal wall up procedures are: it is usually a staged procedure, so patient has to come for surgery twice or thrice, and in between patient has to come for inspection. There is relatively high rate of recurrent or persistent cholesteatoma. Canal wall down procedures. The advantage of canal wall down procedures are: usually it's a single procedure, so patient does not require repeated procedures. There is a low rate of persistent or recurrent cholesteatomas because you can inspect and remove during surgery itself. There are certain disadvantages of canal wall down procedures, like enlarged external auditory canal. Again, that might be some form of cosmetic problem. Hearing aids difficult to fit. If the patient requires hearing aid fitting, then it will be a problem. Periodic canal cleaning is needed. Patient has to come periodically for approach tympanoplasty. Patient has to come for inspection and sometimes removal of disease. But in case of canal wall down procedures, patient has to come for periodic canal cleaning only. Then occasional problem will happen with water exposures, so we advise the patients who undergo modified radical or radical mastoid surgeries to avoid water in their ears. Cortical mastoid surgery is one of the commonly procedure surgeries in ear. It is also important for your examination point of view. It might come as short note in the final exams or in MCQs. Synonyms for cortical mastoid surgery are Schwarz operation, simple mastoidectomy, complete mastoidectomy. What are the aims of cortical mastoid surgery? The aims are complete exenteration of all accessible mastoid ear cells and convert them into a single cavity. So the word accessible is very important here. So whatever you can access, you have to remove all the accessible ear cells. Posterior canal wall and middle ear structures are kept intact. So we don't remove the posterior canal wall, it becomes canal wall down. And middle ear structures are kept intact, but you can do myrinoplasty or tympanoplasty. Indications for performing cortical mastoid surgery are incompletely resolved CSOM with reservoir sign. Second is CSOM TT, which does not respond to conservative ventricle treatment for more than 14 days. Acute colistic mastoiditis, masked mastoiditis, as an approach to endolymphatic sac surgery, facial nerve decompression, or CP angle tumors like translabyrinthine approach, and cochlear implant surgery. We should remember that cortical mastoid surgery is the baseline for all the mastoid surgeries. So in almost all the mastoid surgeries, cortical mastoid surgery has to be first done, then only you can perform the other surgeries. What are the steps of surgery for cortical mastoid surgery? So we usually prefer whilst post-articular incision, then there will be dissection of soft tissues and preparation of the graft. Then dissection of soft tissue is carried out and the graft is prepared. Then we have to elevate the periosteum. Then identify the McEwen's triangle, which is the surgical landmark for the mastoid antrum. So once you drill through the McEwen's triangle, then you can expose the mastoid antrum. Then you have to accentuate all the accessible mastoid ear cells starting from mastoid antrum. The mastoid antrum is the largest and most consistent ear cell of the mastoid ear cell system. Then once you remove all the accessible ear cells and make a single cavity, then you have to place the graft and drain has to be kept to avoid hematoma. And at last, closure of the wound and mastoid dressing are important because there might be blood collection, so mastoid dressing is very important in mastoid surgeries. You can see post-articular incision here. This is whilst post-articular incision around 8 millimeter. So this is more posterior. Okay, then this the B is usually carried in children because in children the mastoid tube is not well developed, so it has to be side posteriorly, so-called hairline incision. Then you have to go deeper. The soft tissues have to be dissected, and this T incision has to be made. So this is the periosteum, which has to be cleaned, which has to be resected. Then this is the McEwen's triangle. The McEwen's triangle is the surgical landmark for the mastoid antrum. Once you drill through it, then you reach towards the mastoid antrum. So boundaries of the McEwen's triangle have been explained in Anatomy of the Ear and Mastoid class. Once you drill, once you go deeper, then this is the externality canal. This is the posterior bony canal wall. This is the digestive series more inferiorly. This sigmoid sinus posteriorly, tegment superiorly, and this is the mastoid antrum. So the boundaries after cortical mastoid surgery are, this is the middle cleft before surgery, this is the mastoid antrum because this is the largest and most consistent ear cell of the mastoid ear cell system. These are the other ear cells. Mastoid tip is the tegment plate. Then this is the facial breeze and this is the facial ridge. And this is the tympanic membrane and the middle ear cavity is the staging tube. So by definition, you have to completely exenterate all the accessible ear cells of the mastoid cell system. So all these ear cells are to be removed. Whatever ear cells can be seen, that has to be removed. So this is the lateral semester canal, which is the medial boundary or the deeper boundary. The superior boundary being the tegment or the dural plate. The posterior boundary being the sinus plate, and the inferior boundary being the digestive ridge. The anterior boundary being the posterior canal wall, which is not removed or which is not lowered. It is lowered in modified radical or radical mastoid surgeries. Coming to modified radical mastoid surgery. By definition, modified radical mastoid surgery is an operation performed to eradicate disease from the middle ear cavity and mastoid, in which the mastoid and the epitympanic spaces are converted into an easily accessible common cavity by removing the posterior and superior external bony canal walls with preservation of the healthy ossicles and tympanic membrane remnant. This is very important. The aims of doing modified radical mastoid surgery are to eradicate disease from the middle ear cleft in order to make the ear safe and dry and to preserve or improve hearing. Indications for modified radical mastoid surgery are CSOM AA disease with adequate cochlear function, that is serviceable hearing. So when the patient is having serviceable hearing, then we can do modified radical mastoid surgery. When the patient is not having any more serviceable hearing, or when the patient does not hear, then patient has to undergo radical mastoid surgery. What are the principles and steps of modified radical mastoid surgery? They are: all accessible diseased mastoid ear cells along with cholecystoma and granulations are removed as per cortical mastoid surgery. Bony posterior canal wall is lowered. Disease from the middle ear cavity is removed, but normal mucosa of the middle ear, remnant TM, and healthy ossicles are preserved. So this is in contrast to radical mastoid surgery, where we will remove everything except the stapes foot plate. Mastoid cavity and the externality canal become a single cavity separated by middle ear cavity. This is very important. There will be two cavities. One will be mastoid cavity and the EAC, and next will be middle ear cavity. Steps of surgery are: first, you have to perform cortical mastoid surgery. As I told, cortical mastoid surgery is the gateway for all the mastoid surgeries. Then lower the facial ridge and break the facial bridge. Then remove the cholecystoma and granulations from mastoid ear cells and middle ear cavity, but preserve the healthy mucosa, TM remnant, and the ossicles. And at last, perform tympanoplasty and conchomiatoplasty, which are very important things in mastoid surgery. So this is the preoperative figure of the ear. This is the mastoid antrum. These are the ear cell systems. This is the facial bridge. This is the facial ridge. This is the middle ear. As already told, all the disease has to be removed, accessible ear cells of the whole system, that is cortical mastoid surgery, plus bring down the facial bridge, and the facial ridge is to be lowered. It has to be lowered so that we can clean the mastoid antrum and the ear cell system from here. So this is the lateral semicircular canal, which is the medial boundary of the surgery. Okay, and the disease, if it is in the middle ear, it is removed. And see, this is the middle ear cavity, which is beyond the tympanic membrane. The externality canal and the mastoid cavity are a single cavity. The post-operative view of the modified radical mastoid surgery. After surgery, we have to make a large and adequate myoplasty for problem-free cavity, because we have to clean the cavity time by time one. And next, the cavity also requires aeration, because there is a big cavity which is formed by mastoid cavity plus the externality canal, and that needs to have adequate ventilation. So if there is a very small externality canal, ventilation cannot be properly done, then disease recurrence might be there. Radical mastoid surgery, the aims are to remove or eradicate disease from the middle ear cleft and make the ear safe and dry, but there will be no attempt made to preserve the hearing. Let's come to indications of radical mastoid surgery. The indications are chronic suppurative otitis media, etiquantral disease with profound sensorineural hearing loss, with intracranial complications, or recurrence after modified radical mastoid surgery are the strong indications for radical mastoid surgery. Second is limited malignancy of the middle ear. Next is glomus jugular tumor with extensive lesion and osteomyelitis of the temporal bone, so-called malignant otitis externa. The principles of radical mastoid surgery are: all the accessible diseased mastoid ear cells along with cholecystoma and granulations are removed. Then bony posterior canal wall is lowered down. Disease from the middle ear cavity along with the mucosa of middle ear, remnant tympanic membrane, and ossicles except the stapes footplate are removed. This is in contrast to modified radical mastoid surgery, where we preserve these structures. Then station tube opening is closed because we are not grafting the cavity, otherwise the infection can come from the nasopharynx to the ear very easily. And mastoid cavity EAC and middle cavity all are converted into a single cavity. So there will be a single cavity in radical mastoid surgery. There will be 2 cavities in modified radical mastoid surgery, and there will be 3 cavities in cortical mastoid surgery. Steps of surgery. As already told, we have to perform cortical mastoid surgery first. Then we have to lower the facial ridge and break the facial bridge. So facial ridge is lowered, then we have to lower the facial ridge and break the facial bridge. We have to remove cholesteatoma vertebrae there and granulation tissues from the mastoidal system and the mid layer also. Then we have to remove the remnant mid-layer mucosa, TM remnant, and ossicles except the stapes foot plate which is in here. We have to close the eustachian tube opening. Here the eustachian tube opening has been closed. Again, conchomatoplasty is to be performed. In this case, mastoid, then EAC and the mid-layer all become a single cavity. Okay, and the eustachian tube will be obliterated. Now coming to causes of discharging mastoid cavity. What are the causes? The conditions might be inadequate conchomatoplasty, as I have already told, the good ventilation. When there is no ventilation or decreased ventilation, then there might be discharging mastoid cavity infection. Recurrence of cholesteatoma might recur or there might be recidivism. The residual cholesteatoma in facial ridge, synovial angle, mastoid tip, sinus tympani or anterior epinephrum is also common. Persistent infection like petrositis, tuberculosis, sinusitis all might lead to again discharging cavity. Then persistent allergy, retained foreign bodies like cotton ball, and wrong indication for surgery, whatever it was done, also might be the cause for discharging mastoid cavity. Mastoid cavity problems can be reduced by succerization of the cavity, so we can easily clean when there is succerization. So adequate lowering of the facial ridge so that we can easily clean the cavity. Round cavity, complete removal of the disease, white conchomatoplasty for adequate ventilation and grafting the tympanic membrane to avoid mastoid cavity problems. Coming to the last topic for today is combined approach tympanoplasty, CAT. The advantages of combined approach tympanoplasty are will be faster healing of the disease, easier long-term post-operative care, and no water precautions necessary, especially important in children and water sport. This is very important point in relation to other types. More options available for hearing aid if necessary because the cavity, the externality canal looks normal. The disadvantages are epitympanum or mastoid is not accessible to post-operative inspection because this is closed cavity. In supratival space, not easily accessible unless malleus and incus are removed. We usually don't remove malleus and incus in combined approach tympanoplasty. Both residual and recurrent disease are more likely, so patient has to undergo inspection time by time. There are greater numbers of procedures required for disease eradication because, as earlier told, by 6 months we have to do second look surgery, which is not feasible in our setup. The surgical steps of combined approach tympanoplasty, the name itself signifies this is a combined approach from anteriorly as well as approach from posteriorly. So first we have to do cortical mastoid surgery, is the gateway for all the ear mastoid surgeries as we have already explained. So this is the cortical mastoid surgery. Then anterior tympanotomy via tympanomeatal flap. This is a tympanomeatal flap raised and we do the anterior tympanotomy, okay, or so-called lateral tympanotomy. And we do posterior tympanotomy via the facial resection. This is very important. Okay, this is the cortical mastoid surgery has been performed. From anteriorly, disease has been removed from the mid layer, and from posteriorly, the disease is removed from the facial recess. We can remove disease from the mid layer, okay, to some extent from the facial recess also. So disease has been removed from anteriorly as well as from posteriorly by making a window in the facial recess, and we do tympanoplasty. So most of the times the disease might lurk behind these areas and this disease is not removed, okay, and we cannot easily clean the disease from, especially from ATIC itself or from the synovial angle, okay, this is a synovial angle, and from the mid layer. So most of the times as we do cortical mastoid surgery, it is easy to clean disease from the mastoid, but from the mid layer you have to look time by time for the disease, supposing that it might recur or there might be some residual disease. So combined approach tympanoplasty is not usually practiced. In practice, it is usually practiced in children, and when the patient is having some form of water activity, then it is practiced. In our setup, most of the times we perform cortical mastoid surgery and modify radical mastoid surgery, and sometimes radical mastoid surgery when the disease is severe or when the patient does not have adequate cochlear reserve. Thank you. For more videos, please like and subscribe my YouTube channel, Dr. Krishna Koirala. Thank you.